evening, everybody. Welcome to the Fordham University Graduate School of Social Service. My name is Sameena. Azhar. I'm an assistant professor here at GSS. We're excited to have you join us for tonight's event, which is titled Drug Policy, Pregnant People, and Mandated Reporting Laws for Social Workers. So just a few quick housekeeping things before we get started. Please feel free, if you'd like, to introduce yourselves in the chat. If you have questions as the presentation ensues, please feel free to use the Q&A function. We'll be collating those questions and answering them at the end. So please remember that. Just a few acknowledgements also. Want to thank Mercedes Guzman for organizing this event. She's a Fordham MSW student. And to all the folks who helped behind the scenes to put this together, Trish Rodriguez, Connor White, Matt Roach, thank you all. And without further ado, let me introduce our speakers for tonight. So Azhar Malik, LMSW, is a licensed master of social work and research and program associate with National Advocates for Pregnant Women. Azhar received her MSW from Columbia University. Prior to joining NAPW, Azhar served as a program intern for the Community Service Society of New York and the startup organization New Community Collaborative. Outside of NAPW, Azhar is a board member for the National Association of Social Workers, New York State chapter, functioning as Nassau County's division director. Azhar earned her BS in social work, summa cum laude, from Malloy College. And Miriam Mack, JD, is the policy director for the Bronx Defenders Family Defense Practice. She received her JD from Boston University School of Law. Prior to joining the Bronx Defenders, Miriam was a legal fellow at the American Civil Liberties Union of Massachusetts, focusing on issues of racial and reproductive justice. Thereafter, she clerked for the Honorable Solomon Oliver Jr. in the Northern District of Ohio, and then the Honorable Justice Geraldine S. Hines of the Supreme Judicial Court of Massachusetts. Miriam holds a BA in history from Columbia University. So thank you both for joining us, and I'm gonna transfer it over to Azhar and Miriam.
Great, thank you so much, Sameena, for that introduction. Hi, everyone. Good afternoon, good evening. My name is Azhar Malik. My pronouns are she, her, hers. And like Sameena had mentioned, I am a research and program associate with National Advocates for Pregnant Women. And I'm joined with my colleague, Miriam Mack, and we'll be talking to you all today about drug policy, pregnant people, and mandated reporting laws for social workers. So before we begin, I want to take a quick moment to acknowledge the land that we are all on and we are all occupying. So I know many of us are on the land of the Lenape people. I am on and work and reside on the land of the Mack land. And it's important that we acknowledge the land that we are on and occupy for several reasons, but in connection to the work and the issues that we're going to be talking about tonight, reproductive justice and reproductive autonomy is directly connected to land occupation and that type of autonomy. So I urge you all to, if you don't know what land you're currently occupying, to research that land and to figure out ways that you may be able to support your Indigenous brothers and sisters to further the human rights of those people and also for reproductive justice in general. So here are the objectives tonight that we'll be covering. So I'll be providing first an overview of drug policy at the federal, the state, and the local level and the city level, especially as it relates to pregnancy, pregnant women, and also taking into consideration the intersectional approach with race and socioeconomic status as well. We'll then talk about the history of drug policy in the United States and the interwoven connections between various systems like the family regulation, family policing system, and the healthcare system. And then we'll also provide toolkits and ways that as social workers, you can provide support on pregnant women and pregnant people with respect to federal and state and city requirements. So before I begin, I want to, and you may have already picked it up, but I want to quickly note the language that I'll be using and Miriam will be using today. So the first note of language is that I'll be using interchangeably the words pregnant women, pregnant people, and people for capacity for pregnancy. And that's to do two things. That's to acknowledge the history of criminalization that has been directly targeting pregnant women. And then it's also to uplift and answer to that there are folks that do not identify as women that have capacity for pregnancy. And when we talk about inclusivity in our fight for human rights and justice, we want to honor those individuals as well and make space and uplift those voices in this dialogue as well. And the second terminology that we'll be using in lieu of the child welfare system is family regulation and family policing. And that's to accurately and to define what this system does and the role that it has on policing and regulating specifically low income, Black, Indigenous, and people of color into these systems, and the separation and the harm that it actually does. So we can talk more about that in the discussion portion, but I wanted just to raise it for folks. So a little bit about National Advocates for Pregnant Women. So we were founded in 2001, and we are an organization that advocates for the rights of pregnant and parenting people, focusing specifically on those who are most likely to be targeted for state control and prosecution. So this typically means low-income women, women of color, and women that use or engage in substance use. We do this work in three main ways. We do it through legal advocacy and legal defense. We do it through promoting public education and dissemination of information. And we do it through organizing at the federal and at the state level with coalitions and grass-top partnerships. So National Advocates for Pregnant Women defends people who are pregnant and who may have attempted to have an abortion, are mistaken as someone who has an abortion. We defend people who are pregnant and experience a pregnancy loss. We defend people who are pregnant and experience pregnancy, labor, and birth. And we defend people who are pregnant and use alcohol or drugs. So the population that we serve are typically people who, but for their pregnancies, would not be criminalized. And our clients face an array of charges at the national level, and state by state, this varies. But these charges are not limited to murder, manslaughter, criminal child neglect, criminal child abuse, chemical endangerment of a child, abuse of a corpse, and so on and so forth. We also see at NAPW that at the same time that our clients are facing criminal charges for behavior or their pregnancy outcome, many of them start to become involved in the family policing system, and they start to have open DCF or ACS cases. And we see this particularly with our clients who are charged for using substances or alcohol while they are pregnant. So Miriam and I will talk about the different intersections that we see the surveillance and the criminalization of pregnant and parenting people happening. This is just an infographic to help kind of shed light to the different systems where this is happening. So it happens at the law enforcement system, it happens at the judicial system, it happens in the medical and the healthcare system, and it also happens at the family policing system. So today, apologies for the ambulance in the background if you can hear it. But to date us back and to provide a history of the war of drugs in the United States, I want to date us all the way back to the 1800s when we start to see drugs being introduced into the United States. So back then, opioids and cocaine were known and popular, and they were highly unregulated at the time. In fact, they were unregulated in the same ways that abortion was unregulated. This is not much information that many people know, but it's an interesting point to kind of relate the parallels, especially to what we're seeing today. So opioids and cocaine were common painkillers, and by the American Revolution, they were a common medical tool that doctors were using. In the 1890s, we see cocaine being offered to millions of Americans' homes, and this is a catalog, this Sears and Roebuck catalog, that promoted, syringes and small amounts of cocaine for $1.50 to American homes. And this is to kind of show the cultural practices of how these drugs were being used at the time. And to just reiterate, these were drugs that were used predominantly for pain relief and less widely for recreation at the time. In the late 19th century, we start to see a shift towards regulation, and this is in part due to increase of immigration that is on the rise in the United States. And this is largely due to economic anxiety and fear that these different races would start to take away jobs from the American people. The earliest examples of this is the first anti-opium laws that were enacted in the 1870s to Chinese immigrants who were coming in during the California Gold Rush. In the early 1900s, we see the first anti-cocaine laws that were directed at Black men in the South. And then in the 1910s and the 1920s, we see the first anti-marijuana laws in the Midwest and the Southwest, which are directed directly at Mexican migrants and Mexican Americans. So drug regulation really starts to hit its peak when Nixon takes office in 1969. And we really start to see at this moment the federal government implement racist tactics to target Black and brown communities. So at the time, even though it was a little covert, Nixon and later his former aide admit that the War on Drugs campaign was a way just to jail anti-war drug hippies and Black people and not based on any science. So I'm going to play a short clip from Drug Policy Alliance, Cassandra Federic, who's their executive director, speaking to this war on drugs.
In 1971, Richard Nixon declared a war on drugs.
America's public enemy number one in the United States is drug abuse.
He lied.
In order to fight and defeat this enemy, it is necessary to wage a new all-out offensive.
50 years later, the real public enemy number one is clear. It's not the drugs or the people who use them. The real enemy is the drug war itself and the policies and systems that feed it. Nixon's own aide admitted the drug war was never really about drugs. The war on drugs is a tool for racial and social control and criminalization, surveillance, and punishment. Black and white people use and sell drugs at a similar.
So the video cuts off to, but Cassandra goes on to state that Black and white people use and sell drugs at similar rates, but Black communities make up 26% of arrests, but they are just 13% of the US population. So we see that big disparity and the disconnect of who's being policed and who's being targeted. At this time, also, we see drug control agencies bloom. And when Ronald Reagan takes office, he continues to focus on this anti-drug campaign, targeting the victims of the war on drugs, as opposed to the people that were supplying the drugs at the time. Ronald Reagan's wife also takes a similar approach and launches her Just Say No campaign, which was, again, at the time where the US was turning a blind eye towards cocaine smuggling that was happening. And we see at this moment racial disparities in the prison population rise. And this is the start and the increased rise in mass incarceration. So I say this predominantly for one reason, and that's the example of crack and cocaine and the different penalties and the treatments that were being used from the same drug. So crack and cocaine are the same drug. Crack is just a smokable form of cocaine, but they were really treated really differently. Crack was majorly put in Black and low-income communities, and they were resulting in harsher sentences and punishments and incarceration, as opposed to cocaine, which was known as more so of a rich white man's drug, which didn't have as harsh of a penalty or an incarceration component to it. So so the war on drugs starts to grow in the 1980s when the public health crisis known as the crack epidemic is introduced. So crack at the time was incorrectly believed and pushed to believe that you permanently and uniquely damaged a fetus, and instead of applying a harm reduction and treatment model approach, we start to see prosecutors targeting predominantly Black mothers, basing a single positive toxicology report as child neglect and/or child abuse. This crack baby myth and the racist tropes that were tied into it was perpetuated by the media with, posts from the New York Times, the Washington Post, deeming Black mothers as unfit to parent and at fault for their children. And it was basically a vehicle that was justified to control and continue the control of Black people. Dorothy Roberts is a scholar, and other scholars talk about this as well, but writes a really great book that's on this topic and folks are interested. So in connection to the war on drugs and pregnancy, we see the damaging rhetoric and the tactics of state actors to address drug use and pregnancy reached new levels in the country in the late 1990s. And this is what the case Ferguson versus City of Charleston. This is a case that was found in South Carolina, where state hospital was collaborating with local police officers to search pregnant women and new mothers for evidence of drug use. This was done without their warrant, and this was done without their consent. And instead, again, like to use this information to provide appropriate medical care and or treatment to that pregnant patient if they needed it, medical staff was directly handing over this confidential medical information to the police, who were then arresting women right out of their hospital beds. This case went all the way up to the United States Supreme Court in 2001, which ruled that the Fourth Amendment protected pregnant people, even those that were engaging in substance use, from warrantless and unreasonable searches. And so while warrantless and unreasonable searches have been deemed unconstitutional, pregnant people who engage in substance use in the past or who have positive results in their toxicology reports are uniquely classified for subject to criminal charges based on presence of substance exposure in their system. And they're then involved into the family regulation, family policing system. Every other type of person that is charged on drug-related offenses is typically charged for drug possession as opposed to drug use. So I want to quickly talk about the progress that we're seeing today in relation and the separation from the war on drugs and that propaganda. So today at the state and federal level, we're seeing alternative approaches to addressing substance use and also pregnancy. And this is really because the emphasis on, evidence-based, health-based, and non-punitive framework to addressing drug use. We're also seeing media outlets also come out to address their role and their complicity from the past and the way that they pushed false narratives. Specifically, the New York Times in 2018 had came out with an article called Slandering the Unborn, which addressed its role in the crack baby myth and how its alarmist language led to the role of arrest and family separation, particularly to Black mothers and Black families. Also, I want to point out that we're seeing decriminalization and legalization efforts across various sectors, including but not limited in the nonprofit sector, in the private sector, and the government sector as well. While this progress is really great, and we want to see this progress across all spheres with all types of drugs, illicit or not, we are seeing a rise in the criminalization of pregnancy due to drug use. This is a NAPW 2013 published report study that documents from 1973 to 2005, 413 arrests based on pregnancy behavior or pregnancy outcome that was happened during that time. From 2005 to 2020, we're seeing triple amount of the arrests in less than half of the time. And again, this is based on something that someone may have done while they were pregnant or their pregnancy outcome. So this is a really stark number, and with the and this is in part due for a couple of reasons. It's in recognition from different states of this personhood status for a fetus and the rights of that individual, the rights of that unborn. And it's also in part due to restrictive abortion bans that are happening in various states, which is directly correlated with higher criminalization of pregnancy and maternal and infant mortality rates as well. So looking a little bit deeper into our initial 2013 report, we know that Black, Brown, and low-income people are typical targets for arrest. 27% of the cases were made by healthcare or helping professionals, including social workers. And in our original study, 84% of the cases involved an allegation that the woman, in addition to continuing her pregnancy, had used an illegal drug. At NAPW today, we receive an average of 3 to 4 intakes from folks across the country a week who share that they are either being tied up in the criminal or civil system based on drug exposure or suspicion of drug use while pregnant or post-pregnancy. So while the criminal justice is taking a punitive approach to addressing drug use, specifically in pregnancy, every leading medical and public health group has come out to say that criminal and civil response to pregnancy and drug use is not the answer, but in fact, a deterrent to patient care and health. They also go on to further say that the most effective way to address this issue is to promote health and to promote healthy mothers and babies is by encouraging voluntary and confidential health care. And before I pass it on to Miriam, I just want to quickly talk about drug testing patients. This is a quote from ACOG in their 2020 policy statement that talked about, there's no medical justification for drug testing, and that they oppose drug testing as it has negative repercussions that leads to family separation, and that a positive tox does not indicate harm. It just indicates there is a chemical compound exposure in that system. But I'm going to pass it off to Miriam now to talk more about the role of the family regulation system and guidance, specifically at the New York State level.
Hi, everyone. I'm so excited to be here. Thank you to Fordham for inviting us. I just want to start off by, again, my name is Miriam Mack. My pronouns are she, her, and I'll just share a little bit about the Bronx Defenders. The Bronx Defenders is a community-based holistic public defense office located in the South Bronx. We opened in 1997, and we provide criminal defense, family defense, civil defense, immigration defense, and we help folks with a whole host of access to social services that they may need. And the primary goal of our organization is to promote justice by keeping families safely together and helping families get out from under policing, the various policing systems, which could be immigration, criminal, family regulation, or the eviction system. Next slide, please. So I'm going to talk to you a little bit broadly about the family regulation system or the family policing system. And I also want to note that throughout this second half of the presentation, you're going to be hearing a lot of content that's focused on drug criminalization in the hospital setting. And I know that many of you are social work students and will go on to work in the hospital setting. So this will be directly related to your practice. And there'll be some of you who are not working in the hospital setting, but are otherwise supporting birthing people, their children, their families, right? So you may be a teacher, you may be a social worker in a school, anything like that. This, I want to sort of lift up and make clear that these, though this seems medical focused, an understanding of really what the law is and the impact of reporting with respect to substance use or alleged substance use is still very much relevant. So when you zoom out on the family regulation system, certain things become clear about who it targets and how the system operates. As I think many of us know, the family regulation system disproportionately targets folks who are Black, Indigenous, people of color, and low-income people. And the starkest disproportionalities are among Black, Indigenous, and low-income people. Like its sister policing systems, and when I say sister policing systems, I mean the criminal legal system, the deportation system, and others, the family regulation system functions to maintain structural inequality and hierarchy. It's structured to ensure that certain folks continue to parent on the margins and under the unyielding gaze and control of the government. The family regulation system regulates and criminalizes the lives of BIPOC and poor folks. And I say this, like when I say this, what I mean specifically is that a specific alleged behavior or an alleged parental failing cannot necessarily predict who the family regulation system entraps, right? Critical to this is the identity of the person alleged to have engaged in the specific behavior or the alleged parental failing. And so, as we discussed earlier, as Asha touched on, studies show that folks of different races use substances at largely the same rates. This is true for parenting people. This is true for pregnant folks. This is true for parents. And yet we know that the family regulation system trains its eye specifically on BIPOC folks and poor folks who use drugs or who are alleged to have used drugs, right? We know that the family regulation system is not, as a general matter, bringing cases or taking the children of wealthy people or white people, most specifically wealthy white people who use drugs, even though they use drugs at a rate that's very similar to Black folks, Indigenous folks, and low-income folks. And we have to ask ourselves why. The family regulation system is not regulating the behavior or the substance use of privileged folks, right? And so that leads us to really question, is it actually the conduct that is called into question, or is it the person engaging in the conduct, right? This is a choice. It's a political choice. It's designed into the system, and it's rooted in drug war ideologies. This normative casting of parents, in particular, Black parents, Black women, poor Black women who use drugs while pregnant, as selfish and morally corrupt and a threat to their children, are the very ideologies that motivated and underlined and really pushed forward the drug war. And they're still showing up in family court today. Next slide, please. So when we talk about ACS investigations, an ACS investigation may be called in by a hospital when a birthing person or their infant is drug tested without their consent or even notice that a test is being done, right? And the test reveals a positive drug test result. Another scenario that we may talk about is that, a child is in school and reports to their teacher that, oh, their parent uses some sort of drug, or their parent, drinks alcohol and sometimes acts funny, right? And what this often looks like is that ACS will come in the hospital setting after birth. ACS will come to the hospital, to the birthing person's bedside, and sometimes that very day that the person gave birth, begin a wide-ranging invasive investigation. And behind all of this is the specter of child removal that, frankly, all people in the Bronx, and I would imagine all people in New York City, and especially low-income folks and people of color, know that threat, that specter, is the threat of the state's power to remove their children, okay? And just to put an even finer point on it, right, is when that call is made to the state central register saying a person has admitted to substance use, and in particular, a pregnant person has admitted to substance use, or there's a positive toxicology, whether that call comes from a support person on the outside, like a school counselor, or it comes from inside the hospital, which in fact is more common, what happens is as that birthing person is recovering, right? This can really just be hours after giving birth. ACS will come in, or CPS if you're upstate, and disrupt that critical bonding period, right? The person will be told, perhaps, that they can leave, but understand that to mean they must leave, but their infant is going to be put on a hospital social hold and will not be able to leave with them. And what's at stake here, right, is ACS's power, the family regulation system's power to emergency remove that child, seek court intervention, place that newborn outside of the care of their family. And then the birthing person and the parent only gets to have supervised visits twice a week for 2 hours. Then this is with an infant. And I want to be clear that the harm of removal is not benign, right? So one of the questions we often get is, well, what about the harm to the child if the parent is using substances? Well, number one, I think we have to query the assumption that just because someone uses substances, that automatically amounts to harm. That assumption is not consistent with New York law. And that assumption is also not consistent with the nuance with which we hold parents with privilege who use drugs and also are able to parent their children. And it's not to say that there are never circumstances under which substance use could affect one's ability to attend to the daily things that they need to attend to in their life, including being a parent. But I don't think we can always make that assumption. And if a person does need support, the family regulation system is not support. And as proof of this, there are myriad studies showing that the harm of removal is not benign. Studies show that even short-term removals have effects that are profound on children, right? Debilitating effects even. Studies show that even when children remain in homes where this family regulation system has identified some indicia of neglect or maltreatment, that those children do better in their homes than the children who are removed to the foster system, right? And I also want to note that although the vast majority of cases in New York are not indicated, reports called in by hospitals and reports called in by, which are mandated reporters, are often screened and screened in and indicated and filed in court. And that means that the court will take the word of a mandated reporter, most especially a hospital reporting a positive toxicology, as the sort of given fact that there is some sort of indicia of child maltreatment here. Next slide, please. So I want to just show people, and I know this is like a little small, but I hope you can see it. I just want you to have an example of an oral transmittal report. Oral report transmittal. And this is the report that is created when someone calls the State Central Register or New York's Child Maltreatment Hotline and makes a report of child maltreatment. And the report, in theory, is taken down verbatim and transferred to Albany, and then Albany shuffles out the report to the local family regulation office. So here in New York City, that would be ACS, but upstate, it might be a local DSS office. And after this report is made, then ACS will go out, or the local DSS will go out and make their investigation. So one might think that part of ACS's investigation is to follow up with the person who originally made the call. Sometimes that does happen, but other times, if there does happen, it's a perfunctory call that's not really digging to give more information, right? It's not something that's an expansive sort of conversation about the strengths and weaknesses of the family. It's really just a confirmatory, oh, you made this report. And I want to point to this report, right, where it says, mother gave birth to baby boy, mother tested positive for cocaine, baby tested negative. The roles of the grandfather and female adult sibling are unknown. 8-year-old child, name unknown, or role of 8-year-old child's unknown. And it also says that mother denied using cocaine. She's willing to go to a drug treatment program. She had no prenatal care and visited the hospital twice. The newborn was tested for sepsis. And I want us to ask ourselves, what is absent from this narrative? Number one, the harm to the child is absent to this narrative. There's nothing in here that suggests that that newborn baby had any harm come to it, right? There was any harm that resulted from this situation. There's also nothing that suggests that that 8-year-old child was harmed in any way, right? We don't know anything about the 8-year-old child. And one question that one might have before intruding into a family's life, or one thing that one might query, is if that 8-year-old child is doing well and in school and supported, why are we intervening in this family's life? Right? The newborn was tested for sepsis. What this report doesn't say is that the newborn was positive for sepsis. And that's not to suggest that being positive for sepsis is indicia of neglect. That's not true. There are various reasons why a baby may have sepsis. However, I'm just trying to use these as examples to point out what is missing, what there's so much here that is not said about this family, right? The fact that this parent had no prenatal care. Well, is that thought of in the context of, because people are targeted for these non-consensual drug tests, they are often fearful of accessing prenatal care, where it feels like they're being criminalized and suspect, as opposed to being supported and in a healthcare setting. Next slide, please. So, how can you be an advocate on behalf of pregnant people in your care? And for some of you who will be in the school setting, right? How can you be an advocate, or anyone really, for families that you are supporting, whether it's supporting the children or the parent or some combination thereof? So I want to be sort of very, explicit throughout this presentation that as a public defender, I'm never going to be the one to suggest that someone make a report, right? As a public defender and a person who sort of deeply believes in the principles of abolition around the family regulation system, I'm not going to make that suggestion. But I also am an attorney that understands that we all exist in a world where we have certain constraints on us, right? And many of you will go on to be in positions where you're mandated reporters. And so what you will also hear me talk about is that if you do find yourself in a situation where you feel as though you have to report, how can you reduce harm? Next slide, please. So the first step of ways to reduce harm is know the legal framework and limit ACS involvement or CPS involvement where possible. When we speak to healthcare providers who care for pregnant folks, or we speak to support folks, in schools or whatever, who are working with families, whether the parent is pregnant or not, if the person's a parent, there's a common misconception that number one, in the hospital setting, that health care providers have to, under federal law or some law that they're not quite sure what it is, but have to drug test pregnant people and have to report those results to the family regulation system if they're positive. And furthermore, I think there's a broader misunderstanding among many mandated reporters and just people in general that substance use, whether it's self-reported or a positive drug test or whatever, in and of itself constitutes child maltreatment. I want to be clear that neither federal, state, nor regulatory law in New York requires this. Again, no federal, state, or state regulation requires drug testing, nor does it support the assumption that a positive toxicology in and of itself or a self-report of drugs in and of itself constitutes child neglect. Now, focusing on the Federal Child Abuse Prevention and Treatment Act, which is CAPTA, and then there's the Comprehensive Addiction and Recovery Act, which is CARA, that requires states to implement policies to notify family regulation agencies of babies who fall into one of three categories: affected by substance use, withdrawal symptoms resulting from prenatal drug exposure, or having fetal alcohol spectrum disorder. Notifying CPS does not mean making a report. And there's lots of great guidance from the Department of Health on this that we will get to in the next couple of slides. Their notification is a de-identified notification that's made through a certain portal, and this will be more relevant to folks who are in the hospital setting. And it gives an overarching sort of report to the federal government so they can track these things. I also want to lift up that, you know, the distinction between a notification and a report is key, because many assume that, oh, what it means to support a pregnant person who may be struggling with substance use, or a parent who reports substance use, is, oh, that means to tell ACS or CPS, right? Because that's where the support and help is. That is not correct. That is not correct. And just because a person self-reports where there's evidence of substance use, that in and of itself does not mean that there is child maltreatment. Next slide, please. And for folks who are more visual and want to check and read things on their own, you can check out the New York State Court of Appeals case from 1995. The New York State Court of Appeals is the highest court in New York, and it made clear that a positive toxicology, so a positive drug test in and of itself, is not evidence of child maltreatment. And I will drop that citation in the chat so that folks can go look it up and read that opinion if they so choose. And so I'm going to actually move on to the next slide, please. So the Department of Health really made this great sort of guidance, which you can see the website link at the bottom of this slide. You can go check it out. They made some really good guidance to help healthcare providers and folks really understand what triggers a need to make a notification for CAPTA-CARA purposes around an infant that's either born affected by substance use. And really what the CAPTA-CARA guidance makes clear is that there's three specific categories, which they outline in the yellow box here. And I really want to draw folks' attention to the blue box at the bottom of the screen, right? Where DOH is really just articulating again the law. That's the law that is been on the books in New York since 1995. The existence or development of a plan of safe care does not require a call to the Child Protective Services. Substance use alone, whether disclosed through the development of a plan of safe care or a self-report, screening, toxicology, or medical record, or newborn has symptoms, is not evidence of child maltreatment. Now, some of you may be wondering, well, what is this plan of safe care, right? Well, a plan of safe care is a plan that the federal government mandates under certain circumstances. And a plan of safe care is really just a plan about how one might support a pregnant person, or might support a new parent and a newborn where there's newborn has been exposed to substance use, right? And a plan of safe care, most importantly, is a plan that can be developed with all different types of support people: case managers, community health workers, discharge planners, doula, home visitor, family member, OBGYN, social worker, right? And so what I think this form and this spreadsheet is trying to make clear is that the need for a plan of safe care does not mean that ACS needs to be involved. The universe of who can develop a plan of safe care in collaboration with a new parent is wide, ranging from family members to friends to doulas to support people. And that is intentional because we cannot assume that substance use in and of itself suggests child maltreatment. And so there's no reason to loop in or unduly loop in the family regulation system unless there is, some indicia of child maltreatment. Next slide, please. And again, this is just to lift up the same point. DOH also made Dear Hospital and Dear Colleague letters to really just sort of spell out what is clear in the flow sheets and in the flow charts. And I don't want to belabor the point too much, but again, we want to pull out from the letter that key component, and a key component to remember whether you're in a hospital setting or not, that just because someone self-reports substance use or just because there's evidence of substance use, that does not mean that there is child maltreatment occurring. That does not mean that automatically there has to be a call there. And in fact, the highest court in New York State has made clear that there has to be something else. There has to be some other evidence suggesting child maltreatment or child neglect, because substance use in and of itself is not that suggestion. Next slide, please. And again, this is just lifting up that same point. Just want to make sure that it's clear to folks and where you can find this in the DOH guidance. Next slide, please. And also we want to lift up the fact that there has been a recent shift in policy in health and hospitals, which is New York's public hospital system. And in fact, I believe it is the biggest public hospital system in the nation. And we bring this up because health and hospitals for many, many years said or claimed they had always implemented informed consent policies, meaning that before drug testing a pregnant person, they would have an informed consent conversation and obtain consent. And after the testimony and protest of many, many people who have been impacted by the family regulation system, and advocates working with them stood up and said, absolutely not. I was tested without my knowledge and my consent. Health and hospitals, after much organizing effort, changed their policies to require that all pregnant people must be informed of that they're going to be that the provider wants to do a drug test, and written consent has to be obtained before testing. And this is an important shift in New York City, but we also want to point out what's missing from this shift. And what's missing is that there is nothing in the policy that pertains to newborns. So at this point, health and hospitals could still very well test without the knowledge and consent of the parent or the newly postpartum person. They could test their newborn, right? And again, it's our position that under the law that they should not be doing this, that before you do anything to a person's child, you have to explain to them what is being done and ask for their permission, both verbal and oral. But that's not reflected in the health and hospitals policy just yet, and we're hoping that shift will come soon. Next slide, please. So if you do make a report, as I was saying, how can we conceptualize harm reduction? Next slide. So many of the important things that you can do to reduce harm if you are going to make a report are pretty basic. Record keeping. Anything you put in writing, including in records, has tremendous weight in the courtroom. And so whether you're writing a court report or whether you're writing a sort of like interim report for school, or you're writing in medical records, or you are the sociotherapist at the school and you are writing in the child's records, what you put in there is important. And remember that families are comprehensive. And so instead of just putting the weaknesses of the parent, you can think holistically and put the strengths as well. That goes a long way for us when we're advocating beside parents and clients in family court. Refer the parent to a family defender. This is key. If you are going to make a call against a parent, tell them. It may be uncomfortable for you, but tell them. and also give them information for a family defender. For those of you who are going to be working in New York City, there are family defenders for 4 out of the 5 boroughs, and that's Manhattan, Queens, Bronx, and Brooklyn. Please, please, please refer them to a family defender. If you don't know the defender in your borough, but you know the Bronx, but you're in Brooklyn, just call the Bronx and we will get the parent a defender in Brooklyn. And I'm going to speed up. Communicate with the parent's legal team, including, letting parents know letting the legal team know what's going on and being responsive to questions. And when you communicate with ACS, remember their role. They are investigating, they are a prosecuting agency. So just remember what information you share can and will be used against a parent in a later family court prosecution. Next slide, please. And then also supporting your patients or supporting the parents and families that you're working with. Refer out. If a family needs support, if they need food, if they need clothing, if they're having trouble with their rent, if they're having trouble feeding their kids, try and refer out to a community-based organization. If you think that's what ACS does, it's really not. ACS refers to services that function to continue to monitor the family and report back to ACS. That is support with the weight over that family of the potential to have their child removed. And then also advocate to remove barriers to trainings or remove barriers to treatment so that everyone, not just pregnant folks, but everyone has access to affordable treatment of all kinds, including medications such as methadone and buprenorphine. Next slide, please. And Asha, I'm going to pass it back to you.
Great. I think given time, we can share the PDF for the slides, which has a lot of the resources that I talk about and Miriam talks about, and maybe we can go to questions and answers. How does that sound, Miriam and Sameena?
I think that's great.
That sounds great. Thank you both for an excellent presentation. I think this is incredibly useful information for all the students or perhaps also already working social workers in the audience today. I think there is a broad misconception, as you've already pointed out, in regard to feeling the need to make a mandated report just off the basis of substance use alone. So thank you for sharing that. So I have a few discussion questions. We have some questions from the audience as well, but this is more of a curiosity of mine, to be frank. But what personally or professionally motivates you to engage in this work? Because it is emotionally, I would imagine, very trying. I've only very briefly worked specifically in childhood sexual trauma. The rest of my experiences have been mostly with adults in addiction treatment, so slightly different from what we're talking about here. But yeah, what are your motivations to do this?
I can start us off. I think coming particularly from a social work degree, I was always interested in social impact and social change and what that looks like. And I also have a paralegal background as well. So the intersection between preserving human rights and doing social change, but also at the community level, and understanding the legal concept and working within that framework, NAPW was a really good fit for me to be able to apply my social work skills and also be within the legal scope of work and to be able to carry on the work, balancing those different intersections. And I think, as many of us know about the news that happened last night, the protections with regards to reproductive justice are really at a critical and pivotal time right now. So it's just even more affirming and compelling to do the work and engage and to stay motivated in it because we're needed here. So I'll pass it off to Miriam for her story.
Yeah, I think sort of in some ways similarly, in law school, I was really interested in and sort of got deep into critical race theory, which then led me to critical race feminism, and really sort of thinking about and interrogating the way in which the law was constructed to uphold white supremacy and marginalization in this country. And that sort of, I really fell sort of like deep into thinking about the ways that women and more broadly, people with the capacity to give birth and marginalized folks, their bodies are regulated and controlled through the law. And one of the primary ways, as Asha was talking about, is through their ability to reproduce. And I started off my career at the ACLU and thinking about reproductive justice very much from the abortion rights or the lack of that right. As we know today, we're at a critical point, but abortion rights have not been real rights for people of color and low-income folks for a long time. But then really wanted to look at the right to have children and to raise children, and how that is something that is also systematically denied from Black and Indigenous folks and low-income folks, but more particularly Black and Indigenous folks. And there's been a history of it. And so that's sort of what brought me to do this work, both on the policy level and also on the public defender level.
Thank you so much. And thanks for also just bringing up, this really pivotal moment in reproductive justice movements. So I wasn't planning to ask this, but it seems impossible to not address this right now. I'd love to hear your thoughts about what this means, or what this might potentially mean for states that have already started to limit or altogether ban abortions. Is it possible that there could be child welfare, family regulation involvement as a result of that act being considered criminal? So I'm just curious about how that might pan out. I don't see that happening perhaps here in New York, right? For those laws locally to change, but for other states where it's already been happening, what that might mean for CPS involvement.
Yeah, no, Asha, go ahead. I think this is a good question for you to hold, and I'll jump in.
Yeah, I'll talk to the criminalization piece of it. So kind of as how I mentioned, in NAPW's 2000 arrest report study, what we had found was from 1973 to when Roe was enacted to 2005, we saw 413 cases of pregnant people being deprived of their liberty or being arrested for something that they did while they were pregnant. From 2006 to 2020, which was 15 years, so half of that time, we saw that number jump to 1,200 cases. And that was when we look deeper into the study, and we're looking to publish that report later this year, early next year, that was particularly in red states where there are restrictive abortion bans, where there is less emphasis on treatment centers, where there is less emphasis on promoting the mother-baby family dyad, and maternal and infant care. So with, with the concerns that Roe may be off the books and this Dobbs decision, we know that this number is probably going to increase, and probably exponentially, especially in these states. And it's going to lead not only to the increased criminalization of pregnant people for behavior, for any type of behavior. It's starting off with, these really controversial things that people can justify with drug use or whatever, but it can become anything that can potentially jeopardize the health or the safety of the unborn, such as falling down the stairs or drinking coffee or anything like that. And also, so we're going to see that, but also we're going to see that maternal and infant healthcare and care is going to go down as well, and unfortunately increased deaths as well in that, but I'll pass it off to Miriam to talk about the family regulation piece and all of that as well.
Yeah, and I think just a quick follow-up. I think that Asha sort of said it right. Like I think what we'll see after this decision is that the world of conduct, or the range of conduct that is criminalized, is going to expand and expand and expand and expand. And I think that we would be naive to think that expansion of criminalization will not also bleed into the family regulation system, such that in states where it's unlawful, where you seek an abortion and it's unlawful, not only will that be used as a basis to put you in a cage, It'll be used as a basis to take your children away from you if you have children already. It'll be used as a basis to expedite the termination of your parental rights under the Adoption and Safe Families Act, right? Because, and I think that that sort of goes to the broader like narrative that we're talking about, or the issue that we're talking about here, where what we are talking about, regulation through reproduction, is this all-encompassing mechanism to control the conduct and the lives of folks who have the ability to become to become pregnant, to become parents, to be parents, who do parent. And so I think we absolutely do have to expect that.
That's great, thank you. Okay, there's a couple of questions in the Q&A that I want to address first, and this will probably put us just at the end of time. So the first question is around Social Service Law 371 4A. How does this law play into reporting requirements around substance use? And the second question, which I'll just say at the same time, is very similar to a question that I was going to ask you anyway about the changes in cannabis regulation, decriminalization of cannabis, or legalization of cannabis in various states, including New York, and how that sort of has affected the work that both of you are engaging in.
So I can just answer quickly for the social services law question. The law in the books stated by the Court of Appeals holds that a positive toxicology or substance use in and of itself is not evidence of child maltreatment. And I want to uplift in the social services law 4A section 1, where it says who's a neglected child means a child under the age of 18 whose physical or mental or emotional condition has been impaired or is in imminent danger of being impaired as a result of the failure of his parent or person legally responsible for his care to exercise a minimum degree of care. And the important thing to point out is that whose physical or emotional condition has been impaired. So therefore, there has to be a causal connection between the parent's behavior and harm to the child, right? And so this idea that you can assume harm is actually inconsistent with the law, whether you're looking at the Family Court Act or the Social Services Law. And hence, the Court of Appeals made the holding that it made in the case that we shared. And then I think for cannabis and being legalized in New York, yes, it's legalized. Just because cannabis is legalized does not mean that folks are not going to be targeted for drug tests. I have heard of some hospitals debating taking cannabis off the drug panel, but thus far in our work, we've not seen it. Cannabis still shows up on drug tests that hospitals do. And you know, I think we have seen a shift in how some courts are dealing with cannabis given MRTA, and honestly, a shift in maybe how the family regulation agencies are prosecuting it. I mean, I think what we see as the frontier is that folks who use cannabis and maybe also have some anxiety or have some, you know, like mental health condition. And a lot of folks use cannabis because they're anxious or they want to just calm down a little bit. That has been framed as problematic or deviant behavior, right? And so it's not specifically straight ahead, oh, you just smoke weed. It's something a little bit more complex and I would say sinister. But you know, I think the other thing that we see that we have to be aware of is that regardless of MRTA, there are hospital systems that are still saying, nope, just call it in. There's a positive toxicology for weed, call it in, let the family regulation system figure it out. So we are making progress, but there's still so much work to be done. And I think that's why it's really important for sessions like this and folks like you all who are students or who are starting your careers or in your careers to be advocating to shift some of these policies.
All right, we are just a little bit over time, but this was super enlightening. I'm so grateful for both of you for taking the time to do this. I'm sure students gained a lot from this. There were a couple of other questions that I had, but I think in the interest of time, we can cut it short. You basically addressed a lot of those issues anyway. So thank you again, Miriam and Azhar, for taking the time tonight. If there's nothing else that you guys want to say, we will call it a night. Yeah? All right. Thanks, everyone.
Thank you so much. Appreciate being here.